It's my great privilege to now introduce Dr. Philip Hoyle, who's the Medical Director for Medical Services for Northern Beaches Health Service, Sydney, New South Wales. Philip has a clinical background in rural general practice. He's worked as a senior manager and medical director in hospitals and health systems, large and small, in Australia and the UK. His previous roles in which he's been active in blood governance include Director of Clinical Governance for Northern Sydney Central Coast Area Health Service, Director of Medical Services and Clinical Governance for Royal Adelaide Hospital and Adelaide Health Services, Executive Director, Director of Clinical Services of Royal Prince Alfred Hospital, General Manager of the Royal North Shore Hospital. Obviously, he brings a great deal of experience. And Philip, please.
Thank you, Lee, and thank you, Mark. We didn't tic-tac, but I think you'll find a certain commonality in our approach. One thing Lee forgot to mention was I'm also the chair of the ACSQHC Standards Committee, and the reason I mention that is that I think one of the great traps we can fall into when faced with standards is thinking it's about accreditation. It's not. We're not in the business of being accredited, we're in the business of healthcare, and we try and do it in a way that's accreditable. So with that little homily out of the way, I'd like to acknowledge, if I may, people who have contributed materially to this. It's always dangerous to acknowledge people because someone's going to get offended by being left out. For example, Sally, I'm sorry I forgot to mention you. So the CNCs in Northern Sydney Central Coast Area Health Service, late and great, Bloodright and clinical governance teams, Dr. Amanda Thompson and Ms. Penny O'Mara, who were instrumental in the work that I'll be reporting. Dr. Stephen Chrisley, who was then the CEO, and without whose courage and commitment it would not have been possible. Professor Leslie Burnett, who was then the head of PALMS, which has been subsumed into Pathology North, executives of the Health Service, and the Clinical Excellence Commission, which exhibited great leadership in making sure this got ahead. It's obvious from this I'm talking about something that happened a little bit in the past, in fact 5 years ago, but there's a reason for doing that. There is more recent work that I could report, but I thought it's actually quite good sometimes to look back, look what happened long ago, far away, besides the wench is dead, and we can have a degree of objectivity about what we're talking about. So I believe that, and I hope, that I've been able to pick out the things that remain material for now. So the overview of this morning's chat is about what governance actually is, because it's a pretty dreadful word, how governance of blood products was implemented in Northern Sydney Central Coast, and some general points on implementation. Very, very happy to be interrupted, but obviously questions at the end also. So let's start with what governance is. Well, governance is, I go for simple definitions. Governance is essentially the exercise of direction and control. As such, it overlaps somewhat with management, but it's a little bit different in that it isn't actually about doing things itself. It's about making sure they're done. And clinical governance is essentially the application of that to clinical care. It's that simple. One subtlety about governance is that we often treat it like a noun, but it's also a verb. It's something we do. It's not this structure that sits out there drawn on paper. It's actually made up of interactions, shared values, shared expectations, beliefs, conflicts, arguments, fun. And if you can conceive it in those terms, you can actually make it work. If, on the other hand, you say, I'm going to appoint someone and set up a committee and that'll be my governance, you've actually missed the point. Hopefully that will come out also as we go through. So, the Safety and Quality Improvement Guidelines, and I found them really good, and thanks to Deb, I now know why I found them really good, actually give, I think, a brilliant description of what governance needs to be. It's about the relationships and responsibilities between stakeholders. For example, the senior executive, the workforce and consumers. That's really, really a classic example of how it's about doing things. Note that that's not about drawing lines on a map. That's about who talks to who listens to who works with who. And in terms of implementing governance, that's what we need to implement, is ways for people to come together to do things. Oh, by the way, I meant to say at the beginning that I'm going to talk about, I took the title of my talk which was delivered to me, very literally. I'm not going to talk so much about governance as about implementing governance, if that's all right. obviously we have to talk a bit about what we're implementing, but how you make it happen, how you set it up is going to be the focus. Because frankly, I think that's a lot more fun. So the relationships, and then it's a system to define and achieve corporate objectives. So have to align roles, interests and all the rest. It's about systems for directing and controlling the organisation, and it's about both corporate and clinical governance. And increasingly the boundary between those is getting blurred, thank heavens. I'm not going to press the pointer because I might do a mark if I do. It's a green, I'll try it, come on, be brave, yeah, right, it worked. So to me that's, and it's in the Safety Quality Improvement Guide. I mean, I've condensed it a bit and the Commission gets really annoyed when people condense things, but there you go. That is, to my mind, a really brilliant description of what governance and governance of any of the standards and any of our health services needs to do. About establishing relationships, having systems to get there, having systems for making sure where we're going is the right place, and then bringing it all together. So why have governance? It's all very well having said what it is, but why would you have it? Well, there's a few reasons. First is we're told to. It's in the standards. I've been told to have governance, I'm going to go out and set it up. Perhaps not the best reason. To link interests. Health services, and there's extensive research about this, are characterised by wildly divergent interests. Managers tend to believe in the bottom line. Doctors tend to believe in the need of the patient in front of them. Managers tend to believe clinical quality should be up there in lights. Clinicians tend to think it should be fairly private. Doctors believe in their experience as the determinant of the next decision. Nurses tend to believe in the literature. The point is there's huge divergence of interests. So you have to bring those together if you're going to take your organisation forward, and governance is a way of doing that. To formalise organisational commitment. And this is, blood is just one of many competing priorities. Those priorities have to be reconciled, prioritised and drawn together. You need a mechanism for doing that that has the commitment of the organisation. I'm sure all of us have experienced going out and saying, please, this is really important. Give me resources, give me authority, give me time to solve this, and people just aren't interested or can't get into it. Governance is about making sure that at least you get an answer. The answer might be no, but no answer is what kills. So governance actually has a hugely important role in terms of legitimating what we do. And accountability to ensure the system works, not just in its own terms, but in the interests of the community and of patients. Because ultimately, blood governance isn't about blood or money, it's about people. And governance is an important way of making sure that that stays there. So how do you know your governance is working? Well, you know it's working when the interests are linked. You can get people, as in Mark's committee that he described, sitting down and agreeing, yes, that's worth doing, that's a good thing to do. You know it's working when the objectives are defined and people own them, have internalised them, say, yes, that makes sense to me. You know it's working when systems are in place. So you actually do know what's going on and you can explain it to somebody and show it to somebody. Those systems might range from having a policy repository to having data on performance to just knowing who's who in the zoo. Accountability and control is actually practiced. It's not just talked about. And objectives are achieved. We'll return to these criteria towards the end of the presentation and see whether what we did got there. So the overview for this morning then, having talked about what governance is now to talk about how governance of blood products and blood management was implemented in the late great Northern Sydney Central Coast Area Health Service. First, it's a bit easy to get overexcited about governance. It actually isn't that hard. So for those who can't read it, it's two elegant witches saying, oh, knock it off, it's only cream of asparagus. And similarly with governance, we often think, oh, Lord, it must be complex, must be hard. In fact, the ideas are blindingly simple. A few of them are a little bit counterintuitive, and if you're smart enough to use those, you can actually become like a retrovirus in your organisation. You can infect finance with clinical values. You can infect the board. You can do all sorts of things. But so I'll share some of those tricks with you and see how we go. So, but first a little bit about the context. In 2005, New South Wales Health, and I want to acknowledge here the leadership of Ken Barker, who was Director of Finance, who I believe was on the NBA at the time, insisted and drove home that we were going to be charging or putting a price on, putting a cost on blood products. Without that, I believe we would have got nowhere. And in fact, I can say that because having just spent the last few years in South Australia, where for some strange reason there's a reluctance to introduce a price for blood products, it's so much easier because you can do a business case. This is actually costing us real money. Hence, we were able to get the clinical nurse consultants. Excuse me, there's a business case, there's an investment. This isn't funded from a cost avoided. This is funded from money we're wasting. And it worked brilliantly. Northern Sydney Central Coast had been formed at almost exactly the same time by a merger of two prior health services, which have since split apart again. And it had 7 hospitals, 2 teaching and 5 district. It had a devolved management structure where basically we had 3 so-called health services within that had a high degree of autonomy, and the area's job was to set the controls and hit for the heart of the sun. Blood utilisation and governance was barely on the radar. It was mainly a safety-related haemovigilance discourse and very little discussion about appropriateness. I mean, there were, of course, some people who were very interested. Oh, now there, I did do a mark that time. I wonder if this... Oh, there you go. I found out what the problem is. It's don't hit the black screen. Right. Who's coming next? Don't hit the black... Right. And the clinical context. There was a long history of leadership in blood use. It was very good to see Professor James Isbister up there. He's ours. We're his. Blood advocacy was, however, done on a shoestring, and it really had only moral authority. And the proceduralists were actively disdainful. So it was an interesting context to put it in. It wasn't an ideal context. Huge organisational change, clinical experts marginalised. However, we had a strategy. First of all, we wanted to target appropriateness and waste. Well, duh. But why? So as to achieve evidence-based practice, patient-centred systems, consent, patient blood management, not that we were using that term in those days, and new clinical norms about blood. Now, this is where the subtlety of the clinical governance game comes out. Note, we're trying to achieve evidence-based practice, patient-centred systems, new clinical norms. We're not trying to achieve financial things. We're using the problem of blood cost to achieve clinical objectives. Subtle point number 1. Governance approach then was to call in the experts. There's often a reluctance to call in local experts, and it's in the Bible, in fact, that prophets are unloved in their own land. And Ross Wilson's now in New York. Show there is a problem and that it matters and that it can be solved. Enable people over it. Set up data and reporting systems. Establish formal leadership and hold people accountable and try to hold on like grim death. We'll go through those in a bit of detail now. Is this pace all right for people? Okay, fine. So calling the experts. Well, there is actually a very good evidence base on blood management, but there's also a very good evidence base on organisational change, quality improvement, etc. People know how to do this stuff. In your own organisations, people know how to do this stuff. You know how to do it. So do other people. And there are enthusiastic experts nearly always waiting to be asked to contribute. Unfortunately, we do have an institutionalised habit of finding an expert from overseas, not always New Zealand, who comes and tells us what to do, and that's often very, very helpful. But in the meantime, there's often someone down there who, if we only thought to ask them or create a platform for them, we could have an even better conversation. So the task in governance is really straightforward. Link them up. So how to link them up? Well, through system design, which I'll talk about a bit more in a minute, system operations, how the system works, get them into play actively, and system oversight. Help them work out whether the system's working and if it's working in the public interest. So point 1, call in the experts, they're around you. So our expertise was quite good. Some we had to appoint, which we went ahead and did. So CNCs, we established one for each of our component health services, and they were brilliant people. We were really, really lucky. I want to acknowledge the expertise and commitment of the laboratory scientists They were fantastic people. The strong medical leadership. We had a 0.4 FTE transfusion medicine specialist funded through PALMS and other leaders, including Mark. We had analytical and improvement expertise through Clinical Governance Unit. A very important point here is the change expertise in local health services. The model we used was to empower local health services. That's subgroups of hospitals, like Northern Beaches and Hornsby, or Central Coast, or North Shore and Ryde, to actually themselves take charge of how they did it, which I think is very compatible with what we've heard today. It was not the area's role, and we should not have tried, and we didn't try to our credit, to tell those people what to do. Instead, we had a chat to them about what needed doing and what they needed to help it happen. And there was governance expertise through the Director of Clinical Governance. So the implications of recruiting the experts are, first, that healthcare is science-based and there are right and wrong solutions. There is such a thing as what works and such a thing as what doesn't work. To know that, you need to know what the hell you're doing. Use expertise to design your solutions. Not every solution needs to come from above. Expert understanding matters hugely, and make local expertise a building block of your governance. At the very least, you're not going to, can I use slightly rude language, piss off people who are just waiting for this thing that they believed in all their lives to come to pass. And furthermore, at the very best, you're actually going to get a detailed operational understanding into play. So, having called in the experts, the next step is to show there's a problem that matters and can be solved. So, first showing there's a problem. Well, blood utilisation, we have very high relative red cell utilisation, greater than 1.5 times what you would expect. It was very high cost, estimated at $9 million at a 33% charge, which was the charge that was introduced, and leading to us to have a potentially avoidable cost within one health service within New South Wales of $4.5 million. Significant amount. And there was little awareness beyond the circle of true believers. Blood was seen as a free good when in fact we all know that it's neither free nor necessarily a good. Nonetheless, that's how it was seen. And unfortunately, it still is to some extent, isn't it? But we'll get there, we'll get there. And this is a measure of inappropriateness. It's called appropriateness, but the appropriateness peaked at 78%. I've got a horrible feeling that was Central Coast, but we won't tell anyone. The rest of us, of course, we had a little bit of work to do. So the governance approach then was to use having shown that there's a problem, this is the next subtle point. Use your problem to build a shared interest. Show people how the problem relates to them and what they believe in. Don't go to them the problem they haven't cared about, thought about, or don't want to know about. Put it in their terms, the way they think it matters. Not hard, but it's subtle. So, the point on that being that the way you present a problem will either get people engaged or it'll make them run away. So there's an art in that. For example, you might go and ask questions rather than tell people a solution, just as a simple thing. It's very much like clinical practice, to be honest. Next thing, having found there's a problem, show that it matters. So to senior management, we showed that not that they needed much persuading, that it was financially important, that there was an external accountability, and that it mattered clinically. Because even the most hard-bitten finance and human resource director is actually in health because they care about care. And show them how this is their way of supporting care. To the blood leadership, it gave them a sense of support. Hold on, the organisation is taking what we care about seriously. The moral dimension is in play. And to clinical leaders, it was a way for us to show that there were risks that they hadn't suspected, such as Lord me, I must have been drinking too much coffee, transfusion-related acute lung injury, etc. And also a risk to their reputation from public benchmarking. You can imagine that relative utilisation rate and appropriateness rate, particularly when published by Clinical Excellence Commission, went down like a lead balloon. Oh, the data's all wrong, the data's all wrong. Probably was, but it wasn't that wrong. I mean, I felt embarrassed too. I'm them, you know, but it was good to be embarrassed sometimes. For senior management then, what we did was conceptually link the financial and clinical issues. So the blood product utilisation rates linked back to DRG costs. costs are benchmarked, and inappropriate use and wastage is visible. For clinicians, this is just an example of what Amanda Thompson went out, and she spent hours and hours and hours and hours out there clinically briefing people on, for example, on the CRIT study, and so showing that RBC transfusion actually was a risk in itself, and if you don't believe me, this is the stuff with respect to coronary artery bypass surgery. The more units you have, the quicker you die. So, the governance implication of showing the problem matters is that no matter who we are in our organisation, the problem impinges on us. Happy with that? So we found a problem, we're showing it matters, but we're not just showing it matters in an abstract sense, we're showing it matters in a concrete sense and in a human sense to people's values as they participate in the organisation. See where I'm coming from about governance being a practice, being a human thing? It's so much more fun too, isn't it? Because you can get out and have a discussion about values, you can get out and have a discussion about what matters in the world, as opposed to, here's this thing I want you to do that you didn't really think about, and you can add it to your list. In a sense, that's why Mark was able to report, and it's not anything to do with me, but it's an example of it working. At his committee, when asked, what did the nurse unit managers think when you impose this on them? Fine, we'll do it. So having shown there's a problem that it matters, I mean, you can't just leave it there. You've actually got to go forward with a solution. So clinical science tells us that there are ways of doing things. There's patient blood management, literature on thresholds, benchmarking, the West Australian work on avoidance and minimisation, South Australia's work on education and proven interventions. And the methods you use in showing there's a solution might be detailing, arguing. You know, there's nothing like going to the surgeons and having a good argument with them. I'm okay on odds of 30 to 1 or less. More than that, I tend to lose. You need 30 to have an equivalent thought. Forcing functions. Start insisting that something happens. Persuasion, visibility, and above all, tenacity. So showing a solution isn't just a matter of sticking something up on the website. It's actually getting out there and slightly violent language, forgive me, rubbing people's face in it. They might like the smell once they smell it, of course, you know. Hopefully they will anyway. So one thing that we did was we established a program called Bloodright, and you can spell that 2 ways. We've spelled it that way. A formal program, had CEO approval. This is the heart of governance. We formalised it. Steve, the CEO, not only approved it, but he took a significant risk given the financial stress we were in to actually accept our business case that it would work. And by the way, it did pay off. We established joint executive sponsors, which was Amanda, who's a transfusion medicine consultant, and myself. We had strong technical leadership from the CNCs, PALMs, clinical governance unit, particularly Penny Amara and Helen Ganley there, and transfusion and the TM specialist. And we reported regularly to Clinical Quality Council, to the clinical directorates, to the executive structures, etc. And very importantly, what we did was we defined very clearly the health service role, particularly the GMs and the directors of medical services within each health service. And we made those enabling roles, by the way, not here's a dead albatross around your neck, but here's an opportunity, this is what we need you to do, and could you give it a go? I've got an example of what that is in a couple of minutes. So the initial focus of the program was on consent, medical documentation, reducing wastage, education, and putting in a forcing function for more than one unit, etc. Amanda exhausted herself trying to do that alone for about a year, and that's real commitment. And when you see the way other people commit to these things, by God, it's energising, isn't it? I mean, it's both vicariously exhausting but personally energising, I think would be the way I put it. Later on, the program is moving towards better management of iron deficient patients, such as patient blood management, developing clinical linkages, particularly through DRG utilisation, and I want to acknowledge the work Paul Tridgell, then working for the CEC, did on DRG relative utilisation rates, which was very, very powerful. For those who aren't aware what DRG is, it's a way of categorising care. And so, for example, your hospital's using twice as much blood as another one for doing an apparently similar procedure, there's at least a question worth answering. And then obviously we tried to improve the clinical governance by reaching down further into the organisation and then to keep it working. A lot of that remained work in practice at the time that the program went away. So the governance implication of showing a solution is that there's something to be done and we all have a role in either supporting that or for it to happen. So recapping, a solution that matters and that we can do something about, and that it's a solution that matters to us, and there's a solution that we can be a part owner of, no matter who you are in the organisation. It all makes sense? This is the heart of governance. This isn't about complying with the standard. This is about working as a team on things that matter and being sure they work okay. Next thing was to set up data and reporting systems. I'll skip over this fairly quickly, but we had various data sets and local data sets, and so we were very, very careful to present it in a scientifically sensible method using statistical process control charts. And this one shows, for example, a 45% reduction in total average cost of whole blood pool platelets at Royal North Shore. It was a nice one to show. Some of the others didn't show any change in other hospitals, and that's fine. So we went out and had a chat and had a talk about it and have a think about it and all the rest, and worked our way through those. Governance implications are that, and why would you have data? Well, obviously you need data for the obvious reasons, but there are some subtle reasons. It keeps the conversation going, doesn't it? And if you're smart about the way you use data, you can keep a positive conversation going. If you go to people and say, here's the number and you look like, then people are going to say, well, my patients are different, or you're an idiot, or something like that. If on the other hand you go to them and say, tell me what, this data seems to mean this, what do you think it means? Go with a hypothesis, not a conclusion. You hook people. How simple is that? How often is it done? Not that often. So having used data, then we established formal leadership. Now, I critiqued my own presentation and said, why haven't I put this up here? Because I thought it might be useful to know the leadership of what before. So I've deliberately put it in this area. Obviously, a lot of this is post hoc rationalisation. But the leadership obviously had to start off quite early. Nonetheless, here it is. So we set up formal governance through the Bloodright program with formal links into corporate governance. For example, finance committee, clinical leadership, and strong support from the pathology provider, who gave us not only executive level support, but actually in cash money in the form of various salaries, gave us very, very good data and expertise and advocacy, including the scientists. So very much a trans-organisational partnership there. This is an example, and I'll read this for you because it's impossible to read at that distance, but this is an example of a note that we wrote to general managers saying, inviting them to participate in what we thought the health service role was. And I'll just read this briefly to you. What we're asking for is your team's active support, that a nominated senior lead person to act as a local champion and actively promote the appropriate use of blood, inclusion in your operational and quality improvement plans, and note the word operational plans there. In other words, it needed to also be in their financial approach, and regular consideration in performance management activities, including at department level. So this is just a simple request to the various health services. This is what we'd love you to do. And to their credit, they did it. So that's an example of formal leadership. So the governance implication of formalising leadership is that leadership and authority structures align the program with the broader corporation. Now, that's once again a counterintuitive statement. What we're doing is we're using the authority structure and the leadership to align what we're trying to achieve with what the organisation's trying to achieve. Now, believe it or not, the moon affects the Earth's orbit. We can do the same. We can drag the organisation, at least in part, in our direction by using governance. It's actually a lot easier than you'd imagine. People know what they're supposed to do, and formal leadership gives the program moral authority and credibility. Nothing beats being able to go out and say, the CEO has signed off on this, and here, ring him up if you don't believe me, and he'll tell you. It works. Next step is to hold people accountable. Well, there's a very important word there, which is people. Now, how many of us think that you can hold a committee accountable? Show of hands. Couple? Right. It's very hard to hold a committee accountable because they will say it was the other bloke. it has to be people. If you're going to have accountability, it has to be personalised. Thank you. So what we did at area level was these poor souls got loaded up with it. The facility level was much more difficult, theoretically clinical leaders, but there weren't many marks around. At clinical level, basically challenging individual behaviours, which was done in great detail. It was very onerous but very effective. So an accountability there. I won't bother you with that. And this is the more formalised side of accountability, so various graphs and things, and those got tabled through various governance committees, etc. But once again, there was an individual at those committees who was responsible for how it worked. So governance implication of accountability is it makes personal capacity, commitment and capability visible, and it forces renewed and ongoing corporate commitment. That's why you need to do it. It's about that ongoing commitment, that renewal all the time. This is not set and forget. And then try to hold the gains. This is where the story becomes a bit sad. That particular organisation at that time was under extreme stress, and shortly afterwards became under extreme stress, and these were battlefield conditions. And there was a change of top-level leadership. Some left more voluntarily than others. And there was an inability to sustain buy-in. In the meantime, the very high levels of organisational stress meant that, frankly, the organisation was burning the furniture to stay afloat. And having achieved significant savings, it was hoped, I presume, I wasn't part of these decisions, and I want to absolutely clear I'm not being critical of anyone here, because that was an appallingly difficult situation, and I honour and respect the people who had the guts to make decisions. But nonetheless, a number of the positions fell fallow, and the energy to sustain the program largely disappeared. It was a bit of a pity, because the program had actually saved millions of dollars and won a New South Wales Health Quality Award for improvements in efficiency. So it was actually an externally validated, effective program. Perhaps most importantly, and these things happen, it's the way the world works, there was cultural regression under conditions of organisational stress. People retreated back into themselves, and the capacity to have the energy to reach out and form ad hoc teams and do things for a little while went away. It's come back since, of course, and it was just a time of extreme organisational stress. But unfortunately, to some extent, the program came undone. The reason I'm telling you this is because things do have a natural life, and because it's okay. You know, we just have to accept that things happen and go, and you can't tell the story of implementing governance without talking about what happened. But there are some implications here. Negative entropy applies. Stable systems require ongoing input of energy, and if a program's disbanded, try and do it constructively, which I believe was done in this instance. So did it work? Getting back to that table of an effectiveness, yes, interests and responsibilities were aligned, they were defined and owned, etc., etc. Just a few general points before I go. Use the problem to build common interests. The problem is your friend. Get experts involved early. Find diverse interests by jointly developing solutions. Draw people in, make them own the solution, not just the problem. Use data and reporting, requires ongoing input of energy, and it's not hard, but it's hard work. Never give up. Finally, if I was doing it again, I'd take a much more patient-centred, less blood-centred approach. Much stronger consumer involvement. We don't all get Russell McGowan's, but occasionally we do. Time and money for clinician leaders. We have to invest in people for it to happen. And the bottom line is, unless you get enough to make it happen, don't go off half-cocked, my advice in retrospect. Empower local services and teams. Link it into the latest, greatest financial flavour, which is activity-based funding, and make sure that there's enough funding for the technical improvements, whether it's carboxymaltose or preconditioning clinics for orthopods, etc. So in conclusion, to paraphrase that great sage of the age, Mr. Homer Simpson, to governance, the cause of and solution to all life's problems. In his case, it was spelt ALCOHOL, but I'm sure he meant governance. So thank you very much.
standard, in terms of things that have changed now, do you think the standard would help insulate change such as you recommend?
I don't know, because would the standard protect us against losing the energy, it being diverted elsewhere? I don't know, because it depends what else it gets diverted to be honest. I think the corporation has to set priorities, and it would give me a stronger argument, I guess, but I don't think ethically I could win it on that. I mean, the choice has to be made.